Hi everyone, I'm going to introduce Krysta here. So we're pleased to welcome Krysta Mino, RN BScN, as one of our RNAO webinar speakers. Krysta is currently a business development manager and educator at Zimmer Biomet, Ontario, where she brings over 10 years of experience in the medical field. With a prior career in the operating room, Krysta has developed a deep expertise in orthopedics, which she now applies to her work with healthcare professionals across various disciplines. In her current role, Krysta collaborates with orthopedic surgeons, sports medicine physicians, pain specialists, and other healthcare providers to educate them on the potential benefits of nSTRIDE's APS, a regenerative therapy treatment for patients with mild to moderate knee osteoarthritis. This therapy has shown promise in alleviating pain, improving joint function, and enhancing the quality of life for individuals living with knee osteoarthritis. For many patients, the use of nSTRIDE's APS has led to significant relief and functional improvement, potentially delaying the need for a total knee replacement. Today, Krysta will share her extensive knowledge and insights on this innovative treatment, shedding light on its clinical applications and impact on patient care.
Thanks, Melody, for that introduction. So hi, everybody. Thank you very much for joining me this evening. I'm hoping that you can all hear me all right. If not, just you can leave a note in the chat. I believe the chat box will be monitored throughout and we'll be addressing questions at the end. But if you can't hear me, again, please just write something in the chat box. So as Melody mentioned, my name is Krysta and I work with Zimmer Biomet. And tonight we're going to be talking to you about orthobiologics, regenerative medicine. Specifically, we're going to be talking about nSTRIDE APS. So let's get into this presentation. It's a little bit scientific, so I'll take it step by step. Okay. So I'd like to start off by reviewing what we mean when we talk about orthobiologics. So as you may know, they are therapies developed from biologic or natural substances that can be used to help relieve pain from conditions such as osteoarthritis or to enhance the body's ability to heal from repetitive use injuries like ligament or tendon strains. So cartilage injuries are also another area of treatment, or even fractures. So orthobiologics can also, in some cases, improve healing after orthopedic surgery. So where does it come from? So essentially there's two types. You have an autologous, which means that it comes from that same person in which it's used. So if you were going to get a PRP treatment, it's autologous because you're going to be drawing the blood from that patient and then using it on that patient. And then you have allogeneic, which is, it comes from another patient. So you probably remember the term allograft. It's a bone graft that comes from another patient. So essentially you can break it down into other categories, but tonight we're going to be specifically looking at the blood derived. So I've highlighted those in blue. And in that category, there's quite a few options, but we're going to focus on PRP and something called APS. So this list, again, is not inclusive. It just kind of gives you an idea of what is involved in orthobiologics. So what is PRP and how does it work? So we're just going to touch on PRP because it's essential to understand PRP before we move into anything further. So PRP is a platelet-rich therapy, and this is a procedure that concentrates platelets. So platelets are isolated during centrifugation and concentrated in the PRP output. So when they become activated after the injection, they release the contents of alpha granules that contain growth factors. So platelets are involved in many processes such as coagulation, angiogenesis, and healing of damaged tissues. So they're an important reservoir of growth factors in the body and to kickstart the healing cascade. So let's dive a little bit closer and see what we can talk about here is growth factors. So growth factors, they're actually naturally occurring substances capable of stimulating cell proliferation and wound healing. So they're important for regulating a variety of cellular processes. They act as signaling molecules between cells. The alpha granules in blood platelets contain growth factors, which begin healing of wounds by attracting and activating macrophages, fibroblasts, and endothelial cells. So some main uses for PRP currently, aside from cosmetic procedures, there are many medical applications for blood-based biologics. One of the more popular uses by far is PRP for treatment of soft tissue injuries. This does have favorable outcomes with a vast amount of literature supporting the use of leukocyte-rich PRP. So some of the benefits would be increased tendon cell proliferation, stuff like increased expression of anabolic genes and proteins, decreased tendon inflammation, leading to healing. So PRP for knee OA is also very popular. PRP in knee osteoarthritis does struggle with many things, and some of these are no output standardization. So every device out there on the market makes something different. And there's no really agreed upon mechanism of action. There's no regulatory approvals for therapeutic indication due to lack of sufficient clinical evidence. And all of this and more lead to no reimbursement by insurance companies. So it is essentially paid for out of pocket at this point in Canada and other areas as well. But we are moving in the right direction. So recently published recommendations from a European ESCA orbit consensus based on a comprehensive literature review by leading European expert clinicians and scientists. So the literature review on the use of blood-derived products for knee osteoarthritis revealed that 9 of the 28 questions and statements had the support of high-level scientific literature, while the other 19 were supported by a medium to low scientific quality. So the 3 of the 28 recommendations were grade A recommendations, and these are: there is enough preclinical and clinical evidence to support the use of PRP in knee OA. And 2, the clinical evidence has shown the effectiveness of PRP in patients for mild to moderate degrees of knee osteoarthritis. And 3, PRP injections have been shown to provide a longer effect in comparison to the short-term effects of corticosteroid injections. So why are we talking about PRP? We're talking about PRP because it does have potential, and regenerative therapies are in high patient demand right now. There is a need to evolve this therapy further to get better pain control and longer lasting results. So the ultimate goal would be to modify disease with future regenerative therapies and significantly delay or cancel the need for surgery. So why are we looking for advancements of regenerative therapies in orthobiologics? Well, as you guys all know, osteoarthritis is a global health issue with numerous pathophysiological factors and is one of the most common causes of chronic disability in adults due to pain and altered joint function. So on the slide, it shows you that one in every 7 Canadians have OA, which is about 4.6 million people. And that number is actually expected to grow to 10 million in the next 30 years, which will be about every 1 in 4 Canadians. So more than half of Canadians with osteoarthritis are younger than 65, with the average age of diagnosis at 50, and nearly 1/3 are diagnosed before the age of 45. And you know that they're having symptoms long before they're diagnosed. So osteoarthritis also contributes to significant economic burden due to the productivity costs, working days lost, as well as treatment cost, of which the arthroplasty options are the most expensive. So what are the options? So the spectrum of treatment options for knee osteoarthritis ranges from non-invasive, more conservative measures like braces, painkillers, physiotherapy, corticosteroids, etc., to invasive procedures like total or partial knee replacements. But there remains greater demand for alternative intermediate treatments and early intervention, something between conservative and surgical that would help treat the symptoms and slow the progression of disease, with the goal of delaying the need for surgical intervention. So as we saw in the earlier slides, the science of orthobiologics is working to bridge this gap in treatment options. And already we have seen the benefits of what general PRP and synthetic supplements like hyaluronic acid can do for symptoms of OA. But as this field evolves, we are seeing our therapies, our blood-based biologics, more tuned in to address specific disorders. So adding to this, today's patients do look very different and are not always ready for surgery. They're often younger, more active, and they're demanding new, efficient treatment options that will accommodate their pain and functional needs. So due to this demand, there has been a surge in research evaluating less invasive biological treatment options. So one of which is the nSTRIDE APS that we're going to be reviewing tonight. So in the next few slides, I'll be reviewing the underlying biologic process that drives osteoarthritis. This is really critical knowledge when understanding how nSTRIDE APS specifically targets those driving factors. So osteoarthritis was long considered a wear and tear disease, leading to loss of cartilage. But progress in molecular biology has deeply changed this thinking. The discovery that cytokines, which are messenger cells, can increase the production of cartilage-degrading enzymes called MMPs by chondrocytes led to an inflammatory theory behind the pathophysiology of OA. So the current paradigm of OA is evolving from a purely mechanical disease towards a complex biological response, connecting biomechanics, inflammation, and the immune system. So osteoarthritis has multifactorial causation. These factors can be mechanical, biological, or a combination of both. It can be primary with no known cause or secondary with a known cause such as injury. So primary OA is more common than secondary OA, but whatever the cause, literature supports that osteoarthritis is linked to a destructive inflammatory cycle driven by key pro-inflammatory cytokines. So what are cytokines? They're signaling proteins that help control inflammation in your body, working with the immune system. But too many cytokines can lead to excess inflammation if not stopped and reversed once the response is no longer needed. So stopping your body's inflammatory response is just as important as starting it, because too much inflammation, as we know, can cause unpleasant symptoms, leading to long-term diseases. So pro-inflammatory cytokines trigger or heighten inflammation. They relay messages that coordinate your body's immune response, and the anti-inflammatory cytokines stop or lessen the inflammation. They relay messages that prevent an excessive immune response that can lead to tissue damage. So with osteoarthritis, these inflammatory cytokines play a critical role in the degradation of the cartilage matrix, by increasing chondrocyte production of matrix metalloproteinase, which is MMP. So we've said that word a couple times now. What are MMPs? So they are groups of enzymes that break down proteins in the extracellular matrix. So they're involved in many physiological processes, including wound healing and tissue repair, as well as several diseases like arthritis. So the major MMP in osteoarthritis is MMP13. This is a collagenase, which is an enzyme that breaks the peptide bonds in cartilage. So it is considered the primary MMP implicated in osteoarthritis due to its specific ability to cleave that type 2 collagen, which is the primary structural protein of cartilage. So the breakdown of cartilage matrix initiates the inflammatory response, promoting a positive feed-forward loop in which inflammatory cytokines induce tissue damage, which then stimulate production of more inflammatory cytokines. So this actually results in a progressive cartilage degradation or degeneration, eventually causing advanced OA. So your body doesn't stop this inflammatory cycle, it's just continuous. So to recap that, because that was a lot, there are key catabolic pro-inflammatory cytokines that become overrepresented And this ultimately shifts the normal balance of the joint in favor of net degradation, leading to pain and inflammation and cartilage breakdown. So zooming in a little closer, we know that the two main drivers of this cascade, the two most prominent inflammatory cytokines, are called TNF alpha and interleukin 1 beta. And these are the primary inflammatory drivers, so, excuse me, stimulating the chondrocytes to produce MMP13 and other MMPs as well that induce collagen degradation. So blocking cartilage matrix breakdown. What would interfere with this inflammatory cycle? How could the body stop it? How could we stop it? So if interleukin 1 beta and TNF alpha are the most important pro-inflammatory mediators in the development and progression of osteoarthritis, the neutralization of these inflammatory mediators simultaneously appears to be a logical development for OA therapy. So how do you block these inflammatory cytokine drivers? Well, going back to what we just discussed, anti-inflammatory cytokines, as we mentioned earlier, help stop or lessen the inflammation. They relay messages that prevent an excessive immune response that can lead to tissue damage. So what cell type can provide the anti-inflammatory cytokine signals? Only immune cells like leukocytes can produce them. The anti-inflammatory cytokine interleukin-1 receptor antagonist, which is a competitive IL-1 receptor antagonist, blocks the signaling activity of interleukin-1, which is the inflammatory cytokine. And this interleukin-1 receptor antagonist, which is an anti-inflammatory cytokine, has no signaling inducing activity of its own. And this is similar with the other ones as well. So you have your soluble forms of IL-1 and TNF, and they reduce their biologic activity by preventing them from binding to surface receptors on the cells, and thus it inhibits cell signaling. So why do I need to know how the underlying biologic process of OA works, and why do I care about how anti-inflammatory cytokines work? Well, when you're looking for a treatment to help alleviate pain related to OA, and to help potentially slow the degenerative cartilage breakdown, this all comes together. So here's where we're going to talk about nSTRIDE a little bit. nSTRIDE APS is a novel orthobiologics approach created with the aim of treating osteoarthritis by targeting that inflammatory pathways that have been mediated by interleukin 1 beta and TNF alpha. Its objective is to reduce pain as well as to mitigate osteoarthritis progression via injection of an autologous protein solution into the joint site. So autologous meaning this is all created from the patient's blood. So APS has high concentrations of anti-inflammatory cytokines and anabolic cytokines, along with low levels of catabolic cytokines. So the output is also accompanied by high concentrations of white blood cells and platelets. So similar to a PRP, you're getting all those great growth factors that come from having concentrated platelets, but you're also getting the added benefit of the anti-inflammatory cytokines. And nSTRIDE APS, we have characterization studies that show that we can preferentially increase the anti-inflammatory cytokines over the inflammatory cytokines. So nSTRIDE APS essentially takes that PRP further by not only concentrating those platelets and plasma proteins, but also capturing those white blood cells. And during the processing steps, the white blood cells get stimulated to produce high concentrations of anti-inflammatory cytokines, specifically interleukin-1 receptor antagonists and the soluble TNF R1 and R2, which are antagonistic to the inflammatory cytokines present in the joint. So essentially, nSTRIDE offers the best of both worlds in regenerative therapy. The concentrated anti-inflammatory cytokines combined with the anabolic growth factors reducing pain and inflammation, and works to restore balance from the previously overrepresented catabolic environment. So nSTRIDE was developed in 2007. Zimmer Biomet created nSTRIDE APS. It is different than PRP since it is based on the activity of white blood cells, as mentioned, and not just platelets. So the nSTRIDE APS kit comprises of two multi-compartmental plastic tubes. The first tube, the nSTRIDE cell separator, contains a tune density buoy, which separates the white blood cells and platelets into small fractions of plasma. So that's step one. The second tube, the nSTRIDE concentrator, contains polyacrylate beads, which desiccate the product via filtration. And this process takes about 20 minutes, and the output is about 2.5 to 3.5 mils, and it contains white blood cells, platelets, and concentrated plasma. So this composition creates a different cytokine output from both PRP and other autologous anti-inflammatories out there. The nSTRIDE APS kit processes the patient's own blood, so it is autologous, it's not synthetic therapy, and it does not require cell culture. Once prepared, the final APS output is administered via intra-articular injection right there at the clinic. So right now you're seeing, this is a grading scale for osteoarthritis. It's a Kellgren-Lawrence scale. 0 means you have a normal joint, and 4 means you have severe OA. So 3 is moderate, 2 is mild, and 1 is, possible but doubtful. So essentially this is kind of what we're looking at when we're talking about patient indications. So patient selection is obviously very important. Indications for APS include patients with mild to moderate, so grades 2 and 3. The earlier the better. And these patients typically want to avoid surgical intervention for as long as possible, and they may even possibly have failed conservative therapy in the past. So those are the ideal candidates for nSTRIDE. And contraindications to nSTRIDE therapy are any inflammatory diseases such as rheumatoid arthritis, and of course, any active joint infection or anything that affects white blood cell concentrations, because this is a white blood cell therapy and you really depend on higher counts of white blood cells to create those anti-inflammatory cytokines because they are the only cell in the body that produces them. So it's also important to note that nSTRIDE APS has Health Canada indications for mild to moderate knee osteoarthritis. And I put up this paper because I think it's a really great, it's really great to talk about this paper after talking about indications because it solidifies those indications a little bit. But in a fairly recently published retrospective study from 2022 by Kuwasawa et al., they compared clinical results by disease severity for knee OA. So they assessed 220 knees with knee osteoarthritis between grades 2, so mild, to grades 4, which is severe. And these are the patients that underwent APS injections, and they used something called the Knee Injury and Osteoarthritis Outcome Score to evaluate performance. So this is a KOOS, it's like a KOOS questionnaire. And if you're not familiar with KOOS, it's a self-reported outcome measure assessing the patient's opinion about the health symptoms and functionality of their knees. So the most important findings of this study are that a single injection of APS for mild to moderate knee osteoarthritis can produce significant pain improvements up to 12 months after the injection. However, the effect did not sustain for severe knee osteoarthritis with Kellgren-Lawrence 4, of a grade of 4. So it's interesting, it talks about here that they ended up following up all the way to 12 months with 148 knees. And each item of the KOOS questionnaire, namely symptoms, pain, activities of daily living, sports, and quality of life, was significantly higher at 1, 3, 6, and 12 months after injection, compared with that at baseline. But then going in and looking at the specific grades, so the KOOS of Kelligren-Lawrence groups 2 and 3, so mild to moderate, they were significantly improved in a stepwise manner up to 3 months, and then the improved status maintained until 12 months. However, Kelligren-Lawrence grades 4, which is severe OA, showed similar improvements at 3 months and at 6 months post-procedure, but the scores at 12 months declined and the significant improvements disappeared compared with those at baseline. So these findings solidify that patients with mild to moderate arthritis, knee arthritis, osteoarthritis, are the best candidates to get better, longer lasting pain relief and will improve in all other subcategories of the KOOS. So this study went to 1 year only, but other studies with longer follow-ups have shown that the effects of nSTRIDE can last multiple years in some patients after just a single injection. So I just wanted to touch on post-treatment period, like how long should you expect to wait before you get pain relief? So most patients, it's 2 weeks. They start to feel significant pain relief, but some are more towards the 8 to 12 weeks, I would say. So you're either getting it right away or it's a gradual increase in improvement. And so we talked a little bit about MMP13 earlier and how important it is because inhibiting MMP13 is very important to preventing the destruction of the cartilage, right? So MMP13, as we know, is the primary enzyme responsible for that cartilage matrix breakdown, and it was significantly inhibited by APS in vitro, demonstrating APS effectively interferes with the cell signaling of interleukin-1 and TNF-alpha. And so this was one study, one preclinical that showed this, and we did have it in a second one. This was our characterization study, but it also showed the MMP levels were dropped or inhibited. So essentially APS inhibited MMP13 production significantly better than whole blood and PRP. And it's important to note that this PRP is a leukocyte-rich PRP that has white blood cells, so it will have some anti-inflammatory effect because white blood cells create both anti-inflammatory and pro-inflammatory cytokines. So you're going to get a little bit of that effect, but APS concentrates it heavily. I have to click for this one. I don't know why, it's just one of those, I have to click for this. So this one's really interesting. APS demonstrated a chondroprotective effect by significantly reducing glycosaminoglycan, that's a mouthful, and collagen release from cartilage explant cultures stimulated with interleukin-1 and TNF-alpha. So glycosaminoglycans are involved in a variety of extracellular and intracellular functions. So some of you may know this already, but I'm just going to review it just in case. But they are important components of the synovial fluid, which is a lubricant fluid of the joints. And then the glycosaminoglycans are also found in connective tissue like cartilage and tendons. So breakdown of this cartilage results in a gag release. And reduction in a gag release is a positive finding, and it shows that APS inhibits the breakdown of cartilage in preclinical studies. So this was another interesting preclinical, and essentially it correlated the increased amounts of white blood cell concentrations and the ratio of interleukin-1 receptor antagonists to the ratio of interleukin-1 beta. So those ratios, if they're over 1,000, directly correlated with improvement in WOMAC pain scores in patients with early knee OA. So higher white blood cells and a higher ratio of interleukin-1 receptor antagonists to interleukin-1 correlated with better pain scores. And then just to touch on this one, because I really think this is interesting. So even though we're concentrating anti-inflammatory cytokines through a filtration process at the end, filtering out inflammatory cytokines and capturing the anti-inflammatory ones, we are also changing the gene expression. So we have compared gene expression in whole blood and in APS after interaction with the beads. And we found that in some subsets of the white blood cells, we actually saw an upregulation of genes for target cytokines. So therefore, we're increasing anti-inflammatory cytokines by concentration, but also upregulation of the gene expression. which is pretty interesting. And just before we get to the question period, nSTRIDE is supported by robust clinical data. This is a lot of the in-human studies right here that's summarized, and some of these are not even published yet. So I'm going to just kind of break down a few of our more key studies here that I think are very relevant. This one here was a multi-center double-blind randomized control trial that compared a single intra-articular injection of APS with saline as the control. So primary follow-ups at 12 months, and then the saline cohort all elected to cross over after the blind was lifted. And then they did long-term follow-up was out to 5 years, and the 5 years about to be published as well. So we're kind of almost finished this study here. So in the graph there below, this shows the WOMAC pain percent improvement from baseline. Statistical improvement from baseline shown at every, there was statistical improvement from baseline shown at every time point except crossover group at 48 months. They kind of dipped a bit there, but overall, it was a great study. And there was 64% survivorship at the 5-year mark, meaning those 64% did not exit the study to get any alternative treatments or injections in their knee. So 65% improvement at 1 year, 70% at 2 year, and then it starts to kind of veer downwards, 50% at 3 years and 39% at 5 years. But it is showing longevity in the results, which is great. And in this study at the 12-month mark, they did do an MRI just to kind of scan and see what's going on and if things are changing in the knee or staying the same. And they did notice that osteophytes and bone marrow lesions in the central zone of the lateral femoral condyles got larger in the control participants, whereas they remained unchanged in the APS-treated participants. So there was no significant differences were found in other compartments. But it's interesting to point out that in one of the animal studies, they were talking about how they should have waited a little bit longer for some of the MRI findings. And I think it's same here. Like, it would be nice to redo these MRI findings and see the difference now, because if we're already starting to see some of these changes happening and the preservation of the cartilage, then it would be great to see what happens at 5 years. But unfortunately, it's challenging to get people back in for these types of scans 5 years down the road. But I'm hoping that in one of our next studies, they'll be doing that. And then this is just kind of a summary of some of our safety studies. The first two, the one highlighted in yellow. So I've highlighted the study in yellow, and then the chart that goes with it is kind of color coordinated. But I just wanted to touch briefly on these because these showed that the APS injection was safe. And it also showed that there was a WOMAC pain reduction. It was about 74% improvement from baseline at 6 months. And the stiffness, function, subscale scores mirrored these results. And then the other safety study underneath, this was a US Progress one. It was a safety study for the US specifically, so it kind of mimicked the first study we had. But again, it proved to be safe, and it had similar results with 72.5% reduction in pain at 12 months. This is all WOMAC pain scale. And then the Progress 3, which is in blue, this was a European post-market registry. And they used the KOOS pain questionnaire, and they noted that there was a reduction at 29% from baseline. This is real world. This is not in a study format, or it's not created in a study format. It's just they're following up. And this was at 12 months, improving 14.3 points. And they did do a breakdown of the Kellgren-Lawrence scales that were being treated in this study, or in this study. And it was pretty interesting because the breakdown, Kellgren-Lawrence 3 had 65.4% of the population getting the nSTRIDE injection, and 14.4 at Kellgren-Lawrence 2. And then the Kellgren-Lawrence 4, there was still about 20% of the population that were getting injected, even though they had severe OA, and nSTRIDE, is not really meant for severe OA. But because it does help with pain, for those people who might not want surgery, but nothing else is working for them, they still do get sometimes 6 months of relief, whereas nothing else would be giving them relief. So that's kind of some feedback that I've heard from some of the clinicians that use this. And then the last one is a patellofemoral arthritis, osteoarthritis study. And all these participants were middle-aged women with advanced unilateral patellofemoral osteoarthritis. And they all previously failed conservative therapy, and they received a single ultrasound-guided injection of APS into the knee. Patients' reported outcomes were collected at various time points, 1, 3, 6, and 12 months. And patient improved, they improved statistically significant from baseline to 1 month and continued up to 12 months. So KOOS pain reduction was around 43% from baseline at 12 months for these. And this is a really challenging arthritis to treat. It's really not responsive to a lot of treatments out there. So it's interesting to see that they got some relief. And patients that didn't get relief after 3 months from their first injection were offered a second injection, and it did show that it did have some benefit for those patients. So it's the first time we've ever offered a second injection because nSTRIDE is typically 1 injection, and you'll have good pain relief for multiple years. Except when you have, severe OA, you might need to come back more often, or if you have any contraindications such as, issues with white blood cells, etc. High responders, again, they have higher white blood cell counts and they have a higher ratio of the interleukin-1 receptor antagonist to the interleukin-1 beta. So that really helps. And then there's more to come. So currently being published, we've got a hip study that showed significant improvement in pain and function scores at 12 months. The 5-year outcome is going to be published from our Progress 2. And again, that was a 64% survivorship at the 5-year mark. And then we have the Progress 4 and Progress 5. So this one, they're larger studies, these ones right here. For the APS versus saline, it was 332 patients blinded. And then the APS against hyaluronic acid, it's like 246 patients blinded, our randomized control trial. So that's all data to come, being published as we speak. So I do have a summary, but I think I'm going to just leave it here for you guys to read, and maybe we can move on to some questions because I did see quite a few questions coming through during the talk. Hang on here. Chat. Okay. Is there a maximum number of nSTRIDE treatments? Can patients undergo 2 to 3 rounds to delay total knee arthroplasty? So that's a really good question. So because it's autologous, yeah, there's no like cap. If your patient, I've seen some patients that were getting it for hip and they had really bad hips. And this guy kept coming back and he's like, yeah, it's getting better. Like he was a pastor and he's like, I can finally stand up and do a sermon, where he couldn't do that for years. So he was just getting them, again, as often as his doctor would inject them. We just say, wait 3 months to get the benefit, to see where you're going to be, because after 3 months, you kind of know if you're going to have improvement from that injection or not. And if you want another one after 3 months, then that's fine. I've even seen some people pair it with, other injections as well, not at the same time, but after, just to like maximize the usage of it. But essentially, we don't have studies to show any of that stuff. This is the studies that we've all done is just nSTRIDE into the joint. And it's mostly been knee because that's where our regulatory approvals are. And that's what we wanted. We wanted regulatory approvals. And like I said, with PRP, there's been no therapeutic standardizations across the board. So, if we can show standardization, if we can show consistent data, and I don't know if you guys know, but it is really hard to do studies in osteoarthritis and biologics in general, because of the placebo effect is very strong. Technically, patients that get saline injections have benefit for 6 months. So where nSTRIDE is shining is in the long-term follow-ups. And that's why I love that they're doing these studies out to 5 years. Like this hyaluronic study we're doing, this hyaluronic acid study, hyaluronic acid does great for the first year. Like patients do get relief from hyaluronic acid, but they're following the study out to 5 years. And the patients that did not get pain relief from the hyaluronic acid, they were allowed to cross over. It's a very complex study, but they were allowed to choose whether they wanted another HA injection or whether they wanted an nSTRIDE injection. And they chose an nSTRIDE injection, and they usually had good relief, whereas they weren't finding relief before. So it's just, it's a different effect, right? You're looking for different things, and we are trying to, we're not saying we're stopping away, we're not saying any of that. What we're saying is we're helping to slow that cycle that we went into detail about tonight. We're blocking those inflammatory cytokines, and we're inhibiting MMP13. And because it's autologous, your patients can have it as many times as they want to pay for it, essentially. Okay, next question. Future thoughts, any evidence to suggest hip treatment may be of benefit? So yeah, so as I mentioned, we are doing a hip study. I believe it's happening in Australia, this study. nSTRIDE is also very big in Australia, huge in Japan. Like it's got regulatory approvals in other countries that and it's taken off. And yes, I see clinicians injecting hips all the time. It's, you know, it's up to them. It's autologous. That's where they're using it. So, but to speak on benefits of that, I need to see the study, which I haven't seen yet. So, any significant differences between genders? Not that I know of. Not that I know of at all, actually. I know that for the patellofemoral study, that was all women, because most of the time it's women that are getting patellofemoral osteoarthritis. And that was a more severe arthritis as well. So it's nice to see that they got some benefit. Post-COVID and delayed surgery due to backlog. This is a positive. Yes. So yes, exactly, Denise, exactly. So when COVID happened, that was, nSTRIDE did pick up a lot because the wait times were huge and patients are in pain, like even mild away, your patients, they're hurting. And conservative treatment options are okay, but they don't last. And, you know, you're kind of hoping to change like the mechanical, if there's a mechanical problem causing wear and tear. But at the end of the day, if that's not corrected, it's just going to progress, right? And it's going to become this inflammatory cascade. Is it covered by OHIP? So just like PRP, right now, it is still out of pocket. It's very unfortunate, but that's why we're doing these studies. We're trying to get, it's one system. It's the same blood draw every time. It's a 60 ml blood draw. Excuse me, actually it's 55 because you're using anticoagulant. And, you know, essentially that's where we're at with that. Like it's the same blood draw, it's the same output, you know, we're trying to get therapeutic standardization essentially to get that coverage. But right now, no, there's no coverage, unfortunately. But we're working towards that. All right, if there's any last couple questions there, if anybody would like some of the studies, you know, referenced, I can do that. I can send them on and we can all have a look at them if we'd like. But yeah.
That was excellent. Thank you very much, Krysta. I managed to figure out my audio, so I apologize. And thank you to Melody for taking over for the introduction this morning. I had a bit of a technical issue, so thankfully I was able to switch computers and still log on for the talk tonight. It was very scientific, but many of us enjoy understanding that. So lots to sort of unpack and go back and look at again. But I really do feel strongly that this is an option for patients who are waiting, and anything we can do to help them to be more comfortable, more mobile, then that certainly has, you know, longevity attached to it. So I'm very, very happy to learn a little bit more about nSTRIDE. Would like to thank Zimmer very much and yourself for your expertise and your time this evening. We can't run these webinars without the support of our vendor colleagues, our industry colleagues. So we thank you very, very much. And before I adjourn the meeting, I want to make sure if there are any final questions, lots of thank yous and excellent presentations. So really great feedback for you. I concur. Very well done. Thank you very, very much for this evening. And if there are no further questions, we will say good night. Everybody stay warm, travel safely wherever you may be, and we'll see you next time.
Thank you so much for having me.
Thank you. Good night.
Bye.